Hello, everyone. Our topic today is about lidocaine in the pain and palliative medicine settings. A little bit of history here. Dr. Nils Lofgren, a Swedish chemist, he's the one that developed this brilliant anesthetic in 1967. And he and his co-worker, Bengt Lundqvist, sold the rights of xylocaine to the Swedish pharmaceutical company Astra. 1948, Lundgren completed his uh, doctorate, xylocaine induced synthetic drug. These are the objectives of our presentation. We'll go through lidocaine, mechanism of action, side effects, and different formulations and applications of lidocaine in pain management and palliative care. Lidocaine comes in different formulations, most important of which is IV lidocaine. It comes in different concentrations, 5%, 1%, 2%, and 4%. So to begin the journey here, we have to differentiate between two types of local anesthetics, the amino amides and the amino esters. In the amides, you will see two I's written here in each of these, like lidocaine, mepivacaine, and bupivacaine. And the esters are one I, procaine, tetracaine, and so forth. Our interest today is about lidocaine, okay, for so many reasons. All right, and we're gonna make a little bit of differentiation between these two types of local anesthetics for, basically our knowledge about, develop our knowledge about local anesthetics. So the esters, they're, they have a faster metabolism because they're metabolized by plasma esterases, while the amides are slower metabolism because they're metabolized by the liver. They're metabolized by dealkylation. Usually, the adverse effects of the amides are systemic toxicity. And while the esters, usually it's the allergic reaction. And this is related to their end product, which is called PABA, or para-amino benzoic acid. There are different mechanisms of action. I'm gonna just go through them quickly, but I have a full lecture on my YouTube channel called Local Anesthetics from A to Z, and I'm explaining all of these mechanisms. So the one that are classically taught in traditional textbooks is sodium channel block. Others like membrane expansion, and this is not the case with lidocaine. This is more with something like benzocaine, lipid soluble agent. NMD antagonist activity, cell membrane restoration, exoplasmic transport blockade, autonomic nervous system resetting, anti-inflammatory, and blocking tissue memory. For the purpose of this presentation, I want you to just focus on only three that I put on red here. Sodium channel blockade, NMD antagonism, and anti-inflammatory effects. And this is just to give you an idea about the anti-inflammatory effect of lidocaine and its There is this is backed by research from from 2003 in the animal lab, and they found that lidocaine inhibits the release of superoxide anions. Okay, uh, you know the other mechanism is releasing um, interleukin 1 beta from human mononuclear cells. It reduces the release of interleukin 1 beta from human mononuclear cells. So there is evidence that lidocaine has an anti-inflammatory purpose. Clinical use. Number one is regional anesthesia. Number two is pain medicine, acute and chronic. Number three, perioperatively by local infiltration. Number four, palliative. As far as monitoring, it needs an EKG. It needs you need to check LFTs before you give the medication. You need to monitor allergic reactions, as we said in ester local anesthetics, and sometimes lidocaine levels, but this is usually in research or not in the clinical setting. Contraindications, allergic reaction to lidocaine. By the way, this is very rare, but it can happen. I've seen it once. It can happen. History of seizure, hepatic or renal insufficiency, severe coronary artery disease, and a history of AV block. Okay, quick question. Clinical uses of lidocaine, regional anesthesia, pain medicine, local infiltration perioperatively, palliative care, all of the above. The correct answer is E, all of them. Multimodal analgesia. I like this slide and I bring it almost in all my presentations. It explains to you at a uh, at a tissue level the different types of medications and how they work, starting from transduction, conduction, transmission, modulation, perception, and CNS response. I mean, you can see here, starting from transduction, topical local anesthetic can play a role. Conduction of the nerve, local anesthetics. Transmission, okay? So you have three levels, the transduction, conduction, and transmission. Lidocaine, again, as we mentioned, blocks sodium channel, and which makes the medication a useful anesthetic and an antiarrhythmic. Also, the blockade of sodium channel modulates neuropathic pain, makes lidocaine a useful analgesic. Lidocaine also has an NMDA antagonist activity, and thus it helps with treating pain. Lidocaine infusion has been utilized in perioperative pain, sickle cell disease, neuropathic pain, and refractory cancer pain. It is well tolerated in most circumstances. However, you can get systemic toxicity if you're not calculating the dose correctly or the patient is not metabolizing the local anesthetic appropriately, like patient with advanced liver disease. One of the rare side effects that we see is something called methemoglobinemia. And this occurs with, especially with benzocaine, prilocaine, and lidocaine. Common side effects are numbness, perioral numbness, sedation, lightheadedness, tinnitus, and headache. Followed by this, you might get seizures and arrhythmias, and these are potentially serious side effects. I want to say that, the first thing that the patient complain about, if he's awake, is basically the perioral numbness. And then he will complain about tinnitus. Okay? So keep this in mind because this is an early sign before they get into seizures and arrhythmias. Lidocaine is metabolized in the liver by oxidative and dealkylation, especially through the CYP1A2 and 3A4. Step 1, lidocaine undergoes deethylation to form monoethylglycine xylidine, MEGX. Step 2, MEGX is further deethylated to GX, glycine xylidine. Step 3, these metabolites are eventually hydrolyzed to 2 and 6 xylidine, which is excreted in urine. Quick question. Clinical uses of lidocaine. Lidocaine blocks sodium channels, correct. Number 2, lidocaine has an NMD antagonist activity, correct. Number 3, common adverse effects include perioral numbness, sedation, lightheadedness, tinnitus, and headache. The correct answer is all of the above. And you can add to this as well, it has an anti-inflammatory action. The 3 mechanisms of action that we talked about: sodium channel blockade, NMD antagonism, and anti-inflammatory properties. This is just to give you a picture of the allergic reactions. And usually this is ester related, ester local anesthetic related. And this could be related to PABA. And PABA is amino ester metabolite or methylparaban, which is a preservative. Usually manifested as rash, hives, laryngeal edema, bronchospasm, or hypotension. While systemic toxicity is basically the side or the adverse effects of amide local anesthetics. And it depends on multiple factors, such as the dose, site of injection, rapidity of injection, etc. Early manifested, as we said, perioral numbness, tongue numbness, lightheadedness, visual and auditory disturbances, twitching, loss of consciousness, seizures, up to coma and cardiorespiratory arrest. Methemoglobinemia is a rare situation, especially with certain local anesthetics, such as lidocaine, benzocaine, and perinocaine. In this situation, the hemoglobin saturation stops at 85%. And the blood, as you see, looks very dark if you take a sample. Lidocaine versus mixilotine. So the oral form of lidocaine is mixilotine. I used to use mixilotine in old days, maybe more than 25 years back, as an anti-epileptic drug for neuropathic pain. The only problem with this drug is it really irritates the stomach big time. And you have to give really a PPI with it. I mean, it's still on the market, but we don't use it. Very rarely used right now. We have much better choices right now, such as the gabapentinoids and so forth. But in old days, we didn't have much choices. So this was one of them, the mixology. Okay, lidocaine dosing. In regional anesthesia, the dosing should not exceed 4 per kilo. And if you're adding epinephrine, 6 per kilo. Okay. Now, as far as chronic pain and palliative care, there has been so many regimens, okay, and routes of administration. However, however, I do believe for the time being, it's safer to use it in a small dose. I use only 200 milligrams to run in 2 hour with monitoring and at least one-to-one supervision. So because I've seen, few cases, but they were very catastrophic for lidocaine infusions. So I would be careful about the drug for the time being until we have real guidelines how to use it in chronic pain. Just use a safe dose, which is 2 per kilo or 200 milligram maximum to run in 2 hours. This is a personal opinion, okay? This is not, I mean, we can argue about it. But as far as I'm concerned, my practice is I don't exceed 200 milligrams. Whether you're having a chronic pain patient, whether you have a palliative care patient, and you want to use an adjuvant to the therapy, I don't exceed this amount, and I do monitor the patient while I'm doing it. The nice thing about lidocaine, you can give it subcut as well. At the beginning, it irritates a little bit, but afterwards, it numbs the area and it really doesn't bother the patient. You can give it IV as well, I mean, subcut or IV. Now, there has been some literature about using subcut lidocaine for complex cancer pain. And this is just one. Of course, they have their own protocol. So if you want to utilize it, it's okay. But I mean, this is the responsibility of the authors. Okay. Another one, intravenous lidocaine for cancer pain without EKG monitoring. Retrospective. Again, I would uh, argue about this. And as I told you, I monitor patients while I'm giving them lidocaine, and I give them for short term, maximum 2 hours, and a limited amount of lidocaine, which is around 200 milligram maximum per session. However, again, you can look up their protocol, and again, it's the responsibility of these authors. Because they're using much higher doses than I'm talking about. Like they're using 5 per kilo to be infused in 1 hour, with subsequent doses to be increased up to 10 per kilo. And this is without EKG monitoring. Another important issue that I really stress on in palliative care rounds, teaching trigger point injections in patients with cancer. I would like to say that 30% of the patients that you see in the clinic, they have myofascial pain, okay? And they will benefit from simple trigger point injections with lidocaine, all right? And I want to say, I used to get a lot of fellows in my pain clinic, and I used to teach them. Only one technique. I explained to them. This is the only one thing that you will learn in, as far as procedures. Is trigger point injections. And they do very well in their clinics, and they help a lot of people. I mean, one-third of the patients that come to the clinic, they can help them out with simple trigger points. I use very diluted local anesthetics and like half percent xylocaine, with or without a touch of steroid dexamethasone. Usually, I don't use except soluble agents. So I use a touch of dexamethasone, like 2 milligrams, for example, if I need to. When you do this trigger point and you release it, you actually release the cycle of the muscle spasm, which reduces the blood flow and causes energy crisis. So you break the cycle, and the blood flow goes back to its normal, and thus you flush all the toxic metabolites, and the pain goes away. Also, we have a transdermal lidocaine. Transdermal lidocaine are used for guys in topical lesions. All right, the most famous is lidocaine patches 5%, and it's very useful in something like post-herpetic neuralgia, for example. As you see here, lidocaine transdermal patches reduce pain in neuropathic cancer patients already receiving opioid treatment. Okay, and I just put some information about this article, and here they're using it mainly in post-herpetic neuralgia. Another article here: transdermal and topical drug administration in treatment of pain. You can look up this one. Another one is the eutectic mixture of local anesthetic. And this is basically a cream called the EMLA cream. It's available in Egypt, by the way, under the name of Pridocaine. Pridocaine. And it's basically 2.5% xylocaine or lidocaine and 2.5% prilocaine, giving a 5% anesthetic concentration. And there is a literature that supports its use in dressing changes and also in the debridement of wounds. All right? It takes some time to work. So you need to put it 20 minutes at least ahead before the dressing. Sometimes I use it for procedures, guys. All right? Sometimes I use it for procedures. Sometimes I use it before I do capsation for post-herpetic neuralgia, the Qtenza, the 8% capsation. It was very painful. So I put EMLA cream, wait a little bit, bring the patient in, and then I put the Qtenza patch. So it has multiple applications, but be aware of toxicity, especially in children, because they have a small body size. Generally speaking, don't use more than 10 grams of 5% EMLA cream. All right. So here, as you can see, the small vial here, it reads 5 grams. So you don't want to use by any means, okay, more than two tubes in adults. Okay, this will give you 10 grams. In children, you have to really calculate the dosage per body weight. Another formulation for lidocaine, that's very important in palliative setting at cancer, is the magic mouthwash. The magic mouthwash is basically several formulas, but generally they have an antibiotic like tetracycline, for example, antifungal like nystatin, antihistaminic, steroid, and antiacid on top of the viscous lidocaine itself. So they do a mix. Okay, usually the pharmacy prepare it for you, and you don't swallow it. All right, you swish and spit. You have to teach your patient about this. It's not something that you swallow. This gives you just like a sample here. Okay, swish and spit 5 ml by mouth 3 times a day. All right, and it has all these, you know, ingredients: antihistaminics, local anesthetic, antacids, antifungal, steroid, and antibiotic. Okay, before we end our presentation here, one last thing is the local anesthetic system toxicity, what we call that. So generally speaking, if you're gonna start using infusion, you should have this intralipid 20% in your uh, emergency kit, all right? And this is in case if you develop arrhythmias, you might need to use it, all right? As far as the seizures, you treat it with benzodiazepines. Of course, the seizures comes in lidocaine before cardiac manifestations. So usually it ends by using midazolam, and less so with intralipid. But things can differ from one patient to another. If you're using something local anesthetics like bupivacaine, you really want to have intralipid around because this can happen. It's rare. It's very rare to happen, but when it happens, it's really pretty serious. Key learning points. Adjuvant analgesics can be beneficial in many types of pain, either alone or in conjunction with opioids. Lidocaine blocks sodium channels, which makes the medication a useful anesthetic and antiarrhythmic. The sodium channel blockade is always beneficial for modulating neuropathic pain, which makes lidocaine a useful analgesic. Additionally, lidocaine is an NMD antagonist, which is also beneficial for treating pain. Lidocaine infusion has been utilized in the perioperative pain, sickle cell disease, neuropathic pain, and refractory cancer. Thank you.